Greetings and welcome. This is Hangouts with HIVE, Reproductive Health for Men Living with HIV. Today, just a couple of days before Father's Day, we will celebrate and discuss the variety of ways in which men engage with their bodies, their sexuality, and their desire to parent or not, and their HIV care. My name is Yamini Oseguera-Bhatnagar, and I work at HIVE, which is a hub for positive reproductive and sexual health. It's the 13th of June in 2017, and I am broadcasting live from San Francisco. Go Warriors to all those basketball fans. Why are we talking about reproductive health for men living with HIV? Of course, my wonderful panelists today will help answer that question by sharing their work, their experiences. But here's a little summary of why we chose to choose this topic for a hangout. In focus groups conducted with men in San Francisco who are living with HIV, men who have sex with women, many men expressed a desire to have a child. Yet most reported that their providers had not discussed reproductive options with them. Many men conveyed a limited awareness of safer conception strategies, of which there are many now. And many participants in focus groups highlighted that the lack of HIV services for men who have sex with women and the need for improved reproductive counseling. This gave birth to many programs and met much work around the country, of which we will hear about some of it. And so without further ado, I'd just like to introduce you to our panel here. I'm joined by some wonderful, brilliant, and brave individuals, and I will quickly tell you who they are. Rana Chakraborty, Shannon Weber and Pete Devine, Guy Vandenberg, Brent Sugimoto, and if we are lucky, our last panelist who's having technical difficulties, Tony Silamon, will join us in a few. I thank each of you for taking the time to share your stories, your knowledge, and the skills that you've acquired through your work today. And I want to share just a little bit about HIVE. Since 1989, HIVE, which was formerly the Bay Area Perinatal AIDS Center, has provided preconception and prenatal care to women and couples affected by HIV. Since 2004, all babies born in San Francisco have been free of HIV, which is a major accomplishment. Our mission is advancing reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. And our vision is to see a world where people affected by HIV have safe pregnancies, reproductive autonomy, access to state-of-the-art healthcare, and most importantly, enjoyable sex lives. A couple of quick tips for viewers before we delve into the rest of the hour. We will broadcast for the next 60 or so minutes. During this time, as you listen to our panelists, please think about questions that you may have about their work, about what they're sharing, and ask them in one of two ways. On your YouTube screen, there's a comment section. It's a running sort of area for questions, comments. Please tell us where you're tuning in from, who you are, and also please ask your questions there, and I will keep track of those and ask them to our panelists later on in the hour. The other way to ask questions is this handy-dandy text message way. You can text your questions to 415-842-2722. That's 415-842-2722, and they come directly to me, and I will add them to my list of questions. If you like what you're hearing, please show us some love on Twitter by using the hashtag HIVLoveWins. Please use the hashtag HIVLoveWins and show us some love on Twitter and all our panelists. If you're watching the video of this Hangout after the live broadcast, you can click on the link in the info section to be directed to a web page with more information and resources on this topic. Awesome. With that, I would love to invite our first panelist to share some background with us. Why is this topic important? What is being done? What's next? And our first panelist is Shannon Weber. Shannon is the director of HIVE and the founder of PleasePrepMe.org. She's passionate about creating a world where women have sex and babies when, where, and how they want to. Take it away, Shannon.
Thank you, Yamini. I'm so excited to be here and talk about seriously one of my favorite topics and be hanging out with some of my favorite people. So I wanted to set the stage about why we're having this conversation, how many people this affects, and how the intersection of reproductive desires and HIV plays out in men's lives. So the CDC estimates that there are between 120,000 and 250,000, so it's a pretty big range, which is to say that we don't exactly know, except that it's a lot of people. So between 120,000 and 250,000 different male-female couples in the US. And that could be where the man's positive or the woman's positive, and all of these folks are of reproductive age. And so from this, we can just gather that there are many people who could benefit from HIV prevention information, family planning, and safer conception services. In the last decade, with the advances in HIV prevention and treatment, really HIV is now seen as a chronic disease, and the opportunities for talking about family planning with folks have really expanded. And we know from qualitative research that living with HIV impacts people's fertility desires, so it dampens it, but it does not diminish it. And we also know that because of the stigma related with reproductive desires and living with HIV, that many people don't engage in preconception care in the same way that we might like them to. So let's be clear, though, that 50% of pregnancies in the US are unplanned. This is among the general population, so it's not as if the general population is that great at engaging in preconception care either, but that number gets a little bit higher when HIV is involved. So given that there's little known about men's living with HIV's reproductive desires, I really want to give credit to Dr. Deb Cohen, the medical director at HIVE, who was visionary, and with Guy Vandenberg and I in 2012 and a small grant from the Macy's Foundation, set out to learn more from men about how they would like to get information, what information they had, how they would like to get it, and then how we could support providers with integrating reproductive health into the primary care setting. So we held focus groups at Ward 86, and Ward 86 is a large primary HIV care clinic based at Zuckerberg San Francisco General Hospital, which is a county hospital. And we did focus groups with 17 men in 2012. 40% were African American, 20% Latino, 45% also reported injection drug use, and 53% were also co-infected with hepatitis C. And we think that this is because of Guy Vandenberg, who will speak later on the panel, was also running a Hep C group, and there was a lot of recruitment that came from that group. There had been such awesome work that had been done with men and women in that group that I think folks felt comfortable coming forward to talk about the Pro Men Project with us. So what did we learn from these groups is, one, that men had some information about HIV transmission and prevention, and some of it was correct and some of it was not correct. So it was kind of a mixed bag. Most said that a provider had never asked them about whether or not they'd wanted to have a child. And we also learned from men that if they'd had sex with men, they essentially kind of passed as a gay man or a man who has sex with men in the clinic. And they believe that that's why providers didn't, again, ask them if they wanted to have children. So another man told us that a provider was more focused on giving information about HIV prevention, so how not to transmit HIV, than talking about reproductive health desires. We also did provider survey, and in looking at provider surveys from around the US, learned that there's really varying level amongst providers about how to talk with men about reproductive health desires. So from this information in 2012, we created a suite of materials through Pro Men Positive Reproductive Outcomes for HIV positive men that have helped shape the suite of materials. So we have printable materials for men, materials for providers as well, and doing provider trainings. And since 2012, we really expanded this concept to not just be men who are living with HIV who have sex with women, but also people of trans experience, men living with HIV who want to be a single parent by choice, who want to co-parent or be in a same-sex couple. Thank you.
Awesome. Thank you, Shannon, for your continued commitment to reproductive health care for all. And thank you for talking about our recent work around safer conception options for people with trans experience and for men who may want to single and co-parent. I will share in the comments section some links, and also later on we'll talk a little bit more about some resources you can access. Thank you for laying the groundwork, Shannon. With that, I would like to turn it over to Pete, who has bravely stepped forward numerous times and inspired many to do the same and told his story. Pete was diagnosed with HIV back in 2006, a San Francisco Bay Area professional musician for the past 30 years. Pete's viral load with treatment through SF General's Ward 86 has been undetectable for the past 6 years. And Pete recently married his old sweetheart from years past, Sandy Bello. Happy anniversary, Pete, and take it away.
Thank you. So my name's Pete. I'm in San Francisco, and so I've been positive with HIV, like Yamini said, since 2006. My viral load's only status has been undetectable only for the past 6 years of that. There's kind of two parts to my story. I was an intravenous drug user for years, and the first 5 or 6 years of that, I was using and I wasn't getting the proper treatment. I wasn't adhering to medication, and I didn't have an undetectable viral load. I got clean about 6 years ago, and since then I've been totally undetectable and totally healthy. So this whole time I was getting treatment at Ward 86, General Hospital, SF General Hospital, County Hospital. I attended the very first pro-men's group that Shannon and Guy facilitated, which was basically a support group at the time for straight and bi men who wanted to have sex with women. And it wasn't until this time, with my newly undetectable viral load status and my continued sobriety, that I was seriously began to have confidence with myself over the issue of having sex and dating and having possible relationships with women, and the strength to disclose to them. Becoming undetectable just totally changed my life. It's a game changer. And a lot of people don't, still in the Bay Area, they don't know that. A lot of people are in the dark about that. They don't understand what it's like to be undetectable and have an undetectable viral load, as opposed to not getting treatment and not being healthy. Through working with Guy and Shannon, and also my incredible Dr. Peter Hunt down at 186. Hi, Peter Hunt, wherever you are. I throw that away. I don't need to read that. Anyways, so we did. I married an old sweetheart of mine. She's negative. She understands that her chances of getting HIV are basically impossible. Shannon Weber actually did the ceremony. She married us about a year ago. She's multi-talented. She's a rabbi. So I find in my life today that many of my friends and acquaintances don't have any experience with HIV, even though, like I say, I live in the Bay Area. I play music, and I play for like a lot of older styles of music, and a lot of the people, my friends and fans, are like of an older generation, and they're very hetero, and they're very like, they just don't have, there are not a lot of gay people, bi people in my life, so it's a whole different subculture I'm dealing with, and I have no problem with disclosure. Anything I can do to break the stigma, to let people know the normalcy of having HIV nowadays, is a good thing. That's what I'm very happy about disclosing and sharing my status with people. And most people in my life are very cool about it, and they just don't know, but they're willing to learn. And I guess basically my motto is it's time for science and people's knowledge to catch up with the science. I mean, it's time for people's knowledge and beliefs to catch up with the science. That's a very important thing. Um, though me and Sandy don't plan on having a baby at this point, it's just I like to speak coming from the angle of breaking down the stigma of having HIV. Share my story. Very important. Thank you.
Thank you, Pete. Thank you for telling your story in different ways, in a lot of different settings, with a lot of different people, and really inspiring a lot of people to walk towards the light in many ways. Pete also co-authored a Huffington Post article with Shannon, which is also an example of something that is truly inspiring. Thank you, Pete, for taking the time to join us today.
For having me. Thank you.
All right. Switching gears, next we're going to hear from Dr. Brent Sugimoto, who will tell us about the amazing work that him and others are doing at Kaiser in Oakland. Dr. Brent Sugimoto is a family physician providing team-based HIV care in a diverse urban setting at Kaiser Permanente in Oakland. Oakland, California, just across the bridge. Brent chairs the KP, or Kaiser Permanente Northern California Committee on Improving Health Outcomes in Minority Gay Youth. So glad to have you among us today, Brent. Take it away.
Thanks, Yamini, and really happy to be here. As Yamini said, I am at Kaiser Permanente in Oakland, and as part of our HIV clinic, it's an outpatient clinic where we provide primary care. So all the patients care for people who are living with HIV. In Northern California, Kaiser takes care of about almost 8,000 people who are living with HIV. And in Oakland, we care for about 1,200. So after San Francisco, we're probably the second largest population. We have the second largest population of people living with HIV. We have a super cool clinic that I'm very proud to work at. It's a multidisciplinary clinic that provides almost kind of wraparound care. Each patient has a case manager, a social worker, a dietitian. We have health education. We have support groups that are there for the patient, just to help them be as healthy as they can be and to help them make the most, to live full, happy lives. Just to give an idea of our demographics here, about 91% of our patients are MSM, either gay identified or bisexual, and only about 9% are people who be identified as men who have sex with women or straight. And of the people who are identified as men who have sex with women, about 82% of them are in minority ethnic groups, and the vast majority of those are African American. In our clinic, the fastest growing population is minority youth, especially minority youth men who have sex with other men, kind of mirroring what's going on within the nation. And I think this kind of determines our focus on reproductive health. So just to give a background, for you people who are not in California, Kaiser Permanente is a large HMO. We're an integrated system. In Northern California, we take care of about 1 out of 2 people in Northern California. And there are a lot of benefits for that, especially for our patients living with HIV who have need for a lot of services here. They get a lot of easy access to things, and that includes the fertility services. However, I guess the downside of that is that there's kind of only one option for them when they come here. So being that we're a large group, the fertility services here, I think, are a little bit more conservative. They're for different partners. It's geared mostly towards heterosexual couples. There's no surrogacy for HIV positive men who have sex with men. And basically the services that they do provide are around prepception. So what the fertility services will do is help the woman in the relationship optimize her chances for conception. And then with ID consult around providing PrEP and making sure that the male partner is undetectable, helping them time the chances for conception with intercourse. So in our clinic, we don't provide anything like sperm washing, no intracytoplasmic sperm injection or IUI, intrauterine injection. And the other thing with our clinic is for the fertility services is that it is self-pay. And with about a large proportion of our patients living with HIV being either on ADAP, our AIDS Drug Assistance Program, or on Medicaid, that means that probably very few of our patients actually get to utilize these services. That said, there are some patients of ours who are interested in becoming parents. But I would say that in general in our clinic, that number is pretty few. That said, this is something that I try and talk to with all my patients. In our population, being a large minority population in Oakland, stigma is a really huge thing. And I'm just happy that there are people like Pete who are out there who are helping to bring knowledge and trying to decrease that stigma, because it just weighs so heavily on our patients. Even patients who have been undetectable for years tell me that every time that they take one of their HIV meds, it still hurts them every day to do that. And it means that they're kind of stuck with their diagnosis and not living their lives as fully as they can. So when I talk with my patients, I do ask them about their aspirations, what they think that living with HIV, how that has changed their minds. And if not prompted, if that doesn't prompt them to talk about their desires to be parents, I often ask them, how do they feel about being parents? And I think that question is important because it raises aspirational issues for them. It makes them think about things other than having an undetectable viral load. And it makes them think about how full their lives can actually be. And a lot of my patients have absolutely no interest in becoming parents, but every once in a while, I'll get a patient who has kind of a light go on in their eyes and makes them think, can actually aspire to in life while living with HIV. And so in talking with them about this, not only keeping our patients healthy, but also trying to keep them as happy as possible. So that's kind of like our experience going on here in Oakland.
Brent, thank you so much for sharing the work that you're doing. There's a couple super key things that you talked about. First of all, reproductive desires are not limited to people of heterosexual experience or for people who have sex with people of the other sex. And also, it's something that it can be gender fluid. And I really appreciate you and folks on your team for taking that on. The other really key piece that I heard from you is that sometimes bringing up conversations among folks who may have a hierarchy of needs that need to be taken care of first. These conversations are still important. They create a sense of aspiration that is really important and really something that everyone deserves to have access to. So I really, really appreciate your work and thank you so much for sharing today. With that, we will switch gears and hear from Dr. Rana Chakraborty, who is joining in from Atlanta, Georgia. Rana is a professor of pediatrics at Emory University School of Medicine in Atlanta. He is the medical director of Ponce Family and Youth Clinic, or Ponce Family and Youth Clinic, the largest pediatric and adolescent HIV clinic in the United States. He was formerly the chair of the Committee on Pediatric AIDS at the American Academy of Pediatrics. His research interests include investigating correlates of protection to HIV and Zika virus at the maternal-fetal interface and the application to vaccine development and linkage and retention care in youth living with HIV. Clearly, there are many interests there. Rana, take it away.
All right. Thank you, Yamini. I like what you said with that word aspiration, especially as it pertains to pediatrics. So I'm going to tell you a little bit about the setting where I work, just very much as with Brent. I'm in a large public hospital here in the US, in the South. We serve probably the largest population of HIV-infected individuals. Nested in that large clinic is the large pediatric and adolescent clinic. We serve what I call from the cradle to the rave, 0 to 25-year-olds. And we have a very mixed population in terms of the aspirations that you speak of. We on the one hand, have a group of perinatally infected, formerly children, now adolescents and young adults. And many of them have grown into sort of their own thoughts and hopes in terms of fathering and parenthood. In terms of looking at some of the young men that come to us, they're a very mixed group. There are those that have those discussions early on and want to engage in discussion about PrEP, want to engage in discussions about PMTCT, and especially if they have significant others in their lives, this becomes an important discussion to have, almost as integral as all the other aspects of their care, including antiretroviral therapy. And therefore, you try and make as many resources available to these young men as you possibly can, trying to obviously keep them undetectable and then link them into clinics where PrEP will become available. If partners on occasion have become pregnant, then there's also discussion about making sure that there's PrEP in place and there's frequent testing antenatally to offset mother-to-child transmission. So that's sort of one group that we see from time to time, and we are developing support services because this is an emerging group where once the battle was getting through childhood, surviving through childhood, now we are talking about other aspects of adult care. There's another group sometimes that are a bit more difficult to engage in. There are on occasion horizontally infected and perinatally infected young men who have fathered children, children being plural there because they may have a number of children and sometimes they don't always pick up on what they should be doing in terms of both prevention efforts and just sort of being just trying to make sure that they maintain responsibilities as fathers, sometimes to multiple children. And that means working with them. We have what I call a medical home model. So we have a psychologist, nutritionist, case managers, social workers, all who can certainly help with those issues and also address other things like food insecurity and housing and so on and so forth. But that in of itself can certainly be sometimes a little bit challenging, but that's also one area. The other group that we have, and it's the largest group of in the patients I serve, are young, mainly minority MSM. Many have come to Atlanta having fled from surrounding states where they've experienced forms of trauma, and they find Atlanta as a city of refuge. They'll leave Mississippi, Alabama, South Carolina, and rural Georgia to come here because of issues around stigmatization. For many, they are in a lot of in abject poverty. There is housing insecurity, there is food insecurity, and in those situations, many such individuals may not necessarily voice that they want to necessarily father or be into parenthood at the current time, but that's something that they may wish to think about or talk about later on as things stabilize, if they choose to live and stay in Atlanta. And again, this group, especially being here in the South, needing a lot of support, which sometimes isn't always coming, where our city is perhaps not as well endowed as some cities in the Northwest, in the Northeast and out West. But we try what we can using our medical home model to at least address some of those needs. My anticipation and word of perhaps of warning and thought is that in the coming decade, with the opiate epidemic reaching out beyond some of the borders of the cities, we will see many more issues around HIV. This will evolve much more in other communities. And I think issues around fatherhood are again going to emerge as a potential prediction for the future, with HIV and hepatitis C and other infections in the background. So I'll leave it there. Thank you again for the opportunity to speak.
Thank you, Rana, for sharing a very important perspective, not only geographically, as Atlanta is a very important place with very high rates of new HIV infection, but also developmentally through the pediatric lens and looking at young people who are seroconverting at higher numbers than any other age group. So I really appreciate your work, really appreciate your heart, your commitment to the community, and thank you so much for sharing your work with us today. Dr. Tony Sillimon is not on our Hangout quite yet, so I will move forward and switch gears to hear from the wonderful, wonderful, wonderful Guy Vandenberg. Guy began working as a hospice attendant and AIDS activist in the 1980s. Today, he works as an HIV clinical specialist at the University of California, San Francisco, where he provides direct patient care at the HIV specialty outpatient clinic at San Francisco General, Ward 86, which you heard about from Pete and others. Guy has provided training, clinical mentoring, technical assistance in Sub-Saharan Africa through UCSF's Division of HIV, Infectious Disease, and Global Health. He is the clinical supervisor at the Richard Cohen Residence for formerly homeless men and women with disabling HIV. He was previously the director of forensic programs at Continuum HIV Services, where he directed programs for HIV-positive inmates. As an independent consultant, Guy also provides training and skill-building services. I don't know what it is that Guy doesn't do, so let's just hear from Guy.
Hi, thank you. Thank you. Welcome to my home in the Mission, and thank you for inviting me to hang out with this wonderful group of people. I'm very excited to be here to talk about this topic of men living with HIV and their reproductive desires and rights. As Yamini said, I work at Ward 86, which is arguably the first HIV clinic, or one of the first HIV clinics, and we're often seen as a leader or a center of excellence, but that doesn't mean that we're perfect. We're a learning organization. We're very much a learning organization, and I think if anything makes us a center of excellence is that we realize that we have work to do, and we continuously need to adjust to the needs that we see. I've had the great privilege of working with the fabulous Shannon Weber for the past 5 years, and with HIVE, an amazing crew of people. And by all means, look at the HIVE website and see the pro-man videos that are posted there. There's a lot of information there, a lot of really good footage of actual people, men living with HIV, talking about stuff, including Pete, who you already heard of a little bit. So this is an amazing time. As Yamini said, I've been doing this for a very long time, and this is a time of great possibilities. We have the technology. We have an amazing toolbox at our disposal. What we need is to connect people to the information and the resources they need to realize their dreams. That goes for patients, and it also goes for providers. And the HIVE website is one of those great places to get connected to the information people need. So how do we do that? We do it through conversation. We do it through, web searches, but most of all, we do it through interaction and conversation. Let me just quickly say, illustrate how things have changed and what is possible. So imagine a young guy in his 20s, let's call him Aaron. He's newly diagnosed. I'm sitting with him, and he realizes that we have technology that is going to keep him alive, that there are medicines that are going to keep him alive. And what he says to me the next day when he meets with me again, and it has sunk in, he said, I feel better. I know I'm not going to die, but I would have loved to be a dad someday. And I guess I can forget about that. So that's Aaron. Think about another guy. Let's call him Rashid. He has been in and out of care. He's a young man, often at times intermittently homeless. He's doing sex work mostly with men, and he tells me he has met a woman that he loves, and she wants kids. And he loves her, and he doesn't want to infect her. And a third guy, Joe, who's a little bit older, maybe in his 40s. Let's call him Joe. And he's been a long-term patient. He has an undetectable viral load. And he hasn't told Ella, who has been with him for the past 5 years, that he is living with HIV. And he says they use a condom most of the time, but not always. So thinking about these guys, there are many, many more stories I could tell, but what do we tell folks? When I started, we told people they tested positive and they had to start planning for their imminent demise. Now we have PrEP and we have treatment as prevention. So everything changed. In 2012, an initiative launched by then BAPAC, now HIVE, we started doing focus groups to see what men really wanted, what services they needed. A lot of guys had been asking about groups. And out of that came these videos that you will see. We did groups, and then eventually it evolved into doing the reproductive health clinic that Shannon and I do once a month. So we change with the times depending on the need. We've learned a lot. When we started, I did some prep work, and we found that in the clinic where I work, where we have about 2,500 patients, about 500 of them have sex with women, men who have sex with women. So we didn't know that. And why didn't we know that? Because very often there's not a good documented sexual history. And we are, the example of the HIV clinic. We're supposed to know this stuff. We treat people for STDs all the time. We don't ask them enough about their sexual practices and who their partners are. So what I started doing is, when I went through that and found, anytime I found a man living with HIV who has sex with women, I would put an ICD-10 code in their problem list. The old ICD-9 code was V26.4. The new one in ICD-10 is Z31.6, and it's advice on procreation, general counseling and advice on procreation. So that any provider who opens their file can see, oh, why is this here? And they might ask me, or they might ask the patient. So lack of documentation is a problem. And then there is a certain level of discomfort among both patients and clinicians discussing stuff. How do I start the conversation? What do I tell them is often what providers ask me. I would rather, have them ask, what do I ask them? They want to know, providers ask me, what is safe? Can I talk to her? the patient's female partner? Where do I send her for testing? Where do I send her for PrEP? Where do I send her for ongoing care? And those answers may differ depending on where you are. You know, I know the answers to those questions here in San Francisco, but if you're in Atlanta, you would have to do some research. But Shannon and I are very well connected, and so we would welcome those questions anytime. Most important thing that I would want to leave you with is start the conversation, live and learn. You're not going to be perfect at it when you start. And when patients want to bring in their partners, I hope that your clinic will encourage that, and that you can do a joint visit. When your patient has issues about maybe disclosing, role play it with them. You know, just role play it. Role play as a provider with a fellow provider how to start a conversation about reproductive health, about taking a sexual history. So there's a lot of stuff we can do. We have amazing tools in our toolbox. Now we need to start the conversation. Thank you.
Thank you, Guy. Your work is known by many. You have been committed to it for a really long time. You've learned a lot, and you're not afraid to share the lessons that you've learned, and I really appreciate that. Thank you for talking to us about the nuts and bolts of how these conversations could be had in an exam room. What ICD-9 codes to use. I mean, these are really important operational questions that people may have. If you have questions, specific questions for any of our panelists, feel free to contact us, info@HIVEonline.org, and we will be happy to triage. There will also be, at the end of this Hangout, a blog in the next day or two that will have a few resources that are put together by us at HIVE, as well as some of our panelists. With that, I would like to open up to question and answers for a few minutes before we share a couple of resources and head on out of here. Thank you. Thank you all my panelists for really just bringing it and telling us about the work you're doing or telling us about your life and your experiences. I will start off with a question for, first question's for Pete, actually. Pete, if you could tell us, what have providers done to support you in moving forward? What has been challenging for you? And what is some advice you would give to another man in similar shoes?
Well, I guess kind of piggyback on what Guy said a few minutes ago. When I was first diagnosed at Ward 86, I thought like basically my life was over too. Like I have HIV, I would never be able to have like sex with anyone who wasn't HIV positive. I would never have a chance of having a child if I wanted to have a kid. And it's kind of like, you know, to be candid, I think there are a lot of people in San Francisco. It's like kind of a subculture of people who are like bisexual, who will have sex with guys and girls, but since they've become HIV positive, they feel like they can only have sex with guys, other HIV positive guys. And, you know, it's a topic that really isn't touched upon very much. And that's one of the great things about HIVE, pro-men HIVE. This is something that the providers and the patients started talking about down at Ward 86. And I was one of those persons. I was bisexual. I was having more sex with guys when I was using drugs and when I was not undetectable, because out of fear of rejection, and out of just having a low self-esteem, not taking care of myself. And I think that's a very common thing down at Ward 86. And I think that's probably one of the greatest things I get out of the groups with Guy and Shannon down there and having treatment down at Ward 86 is to gain confidence in myself, to learn about what being undetectable was and have an undetectable viral load, learning how to adhere to taking my medication every day, and then kind of stepping out of that box and feeling brave enough to disclose to women. And it was very important when I hooked up with an old sweetheart of mine, Sandy, a few years ago. Sandy actually came down to the clinic with me, and we sat with a few providers. Guy was there, and just she learned a lot. We both learned a lot, and just having that option was huge. And that is a very important thing at Ward 86. They're doing wonderful things down there.
Do you have advice for
Do I have advice for a man? My advice is, well, my main advice is, and it's very important, I mentioned it already, it's just like, if you're scared to get treatment, to start treatment for HIV, you shouldn't be. You should get treated. You should try to get healthy. First off, you wouldn't be infectious. You would not be able to pass the virus on if you started getting the proper treatment and adhere to your medication. That's the main thing. Don't be ashamed of having HIV. It's not a bad thing. It's a viral infection that you get from having sex, which is not taboo. It should not be taboo. And it's not fair that the stigma is still going on around this country. I mean, we're in the Bay Area, so it's not quite as bad around here as other parts of the country. But still, you go to the East Bay, you go, 25, 50 miles out of the Bay Area, and it's a lot of people just, they don't know. So I guess my advice is, don't be ashamed if you have HIV, get treatment, try to become undetectable, and a lot of doors will open up for you, and you'll find a lot of confidence and be able to pursue relationships, be able to have children if you don't have children.
Awesome. Thank you so much. There's a question about, the question is, how can we get programs like ADAP and various health insurance companies to cover men's reproductive health issues for both father and child? I feel like, Guy, you were starting to mention a little bit about this, but does anyone want to take a stab at that? It's around coverage and how does that work when men are seeking reproductive health services, which are more so funded for women? Anyone want to take a stab at that?
I can say a little bit about it, but I'm sure that that Brent may have something to say about how it works in the Kaiser system. But so it's an ongoing journey for us to learn about stuff. Of course, for the patients that we take care of at San Francisco General, it being a safety net hospital, virtually everybody is covered in one way or another through government insurance and ADAP. So meds should not be a problem. We found that things like semen testing for men to assess, the fertility, covered by our hospital. A lot of stuff is covered. Things that may be a little bit harder is when it comes to referring to fertility clinics, and so maybe Shannon and Brent have things to add about that.
Yeah. Brent, any thoughts on that from the Kaiser perspective or the HMO perspective?
I mean, I think it's difficult because fertility treatment, when it requires some sort of assisted reproductive technique, is very expensive, and a lot of insurance companies are very reluctant to pay for that. I think some important things are just advocacy, and so legislative action has been important. Tom Amiano, I think it was maybe 3 or 4 years ago, got a bill passed saying there should be equity between heterosexual couples, gay couples, and single parents, and that they should all be covered equally for reproductive fertility access. And so I think that's super important. Another piece of that, and maybe this might be more feasible in the short run, is PrEP coverage, because I think that's going to be much more important, especially for straight couples and use of preception. At least in the Kaiser system, we can get patients be seen for evaluation of whether or not they can start PrEP. But in terms of accessing PrEP, that's a whole different issue with the cost. And maybe with the recent FDA approval of Truvada as being generic, that might change things a bit. But until we can do that, I think that's going to be another thing that's going to get in the way of couples being able to reproduce, to be able to have children. So I think those are two important parts that I can think of off the top of my head.
Shannon, did you want to add anything to that?
So I'm going to add a little piece about the fertility services, which were touched on, which is to say that we have so many options now that can help couples, and it's important for us to make sure that all of those options are available and that really it's a choice. So for some areas of the country, that means to expand and grow your muscle around PrEP. And it might mean to change the language in your clinic around treatment as prevention. And for some other clinics or areas, that means we need to ask questions: why are fertility services so expensive? And why are you making that the first line option? Now, we really want to also make sure that, well, treatment as prevention and PrEP, which may be lower cost and less invasive options, so it may be an option that more people choose. We don't want to ignore the fertility aspect, because for our family and friends who are trans, for our family and friends who want to be single parent by choice or co-parenting couples, or for people who have fertility issues, that might be separate from their HIV, they need access to those services. So we don't want to ignore that and continue to kind of push on that area and say, why is this so expensive? Why is it not available? Can fertility services be covered by insurance? Yes. And for some couples, they have switched their insurance coverage during open enrollment to make that possible for them. That I would just offer one little clue, which is that insurance covers it for fertility issues and not for HIV specifically. So you might want to have a conversation with your provider about how to make sure that option is available for you, because fertility issues can be very common. So it just depends on how your provider makes that referral. And we would be happy to offer consultation to anybody who has questions about these services, how to implement them, or how to ask those questions, whether that's a patient or a consumer who has a question, or if someone wants to reach out and ask us a question about how do they expand these choices that are available in their clinic.
Great, thank you all for your input on that. Shannon, while we have you on the screen, there's a question that I think you can shed some light on. The question is, if the speakers can comment on the recent MMWR paper on safer conception strategies from the CDC, from the perspective of men living with HIV who want to have kids with a partner who is HIV negative. What happens now? What does this mean for us? Shannon, do you want to give that a shot? I know you have something to say about it.
Yeah, since we only have 5 minutes, I may not start. There's some significant issues with the MMWR, so it's hard to get into with the short amount of time that's left. But I can say that we are drafting a sign-on letter. I'm drafting a sign-on letter that HIVE and some other advocacy groups will be putting out, and we would love to get people's feedback on that and signatures if people agree that there's some gaps in the data that's in the MMWR, and the way in which it's presented is not necessarily expanding options for folks.
Okay, I have a question I'd like to ask Brent, Guy, and Rana. What is one small change a clinic or a provider can make now to be more friendly to reproductive health for men living with HIV? Brent, may I start with you?
I think it's just asking, just making sure with all our patients. When you first get a new patient who's newly diagnosed, you're trying to get on treatment, likes to focus on having that person getting undetectable as soon as possible. But that is inevitably tied to everything else. Like, people don't get become undetectable, if they have food insecurity, if they have housing insecurity, if they're facing a whole bunch of stigma. And because they have, like we talked about, a hierarchy of needs, competing interests. And I think that a desire to have a family is an important part of that. You know, like creating a space that's open to talk about anything, you know, means you have a patient who can talk about all their barriers to taking care of their health, and talking about family and their desire to have a family is an important part of that. And so I think just asking the questions there, that's going to get you a very long way towards creating that space.
Just like building rapport is probably the biggest building block of patient-provider relationships. Guy, do you want to add anything to that? I know you have a bunch of tips that you already shared, but is there one takeaway for folks at clinics, providers or clinics as a whole, changes they can make now?
I think Brent really summed it up brilliantly. Just start the conversation, ask questions. Like, you know, it could be, you could do it in many different ways, you know. And I often ask people, if HIV weren't in your life, how would it look different? To explore, you know, what that would be like for the patient. But I think the only thing really that I can add is start the conversation with your colleagues, you know, and that means colleagues across disciplines, physicians, nurses, social workers, peer educators, anybody in your clinic. We all have a part in this.
Wonderful. We've heard from Brent about the importance of talking to your patients, building that relationship. We've heard from Guy, who echoed what Brent said, but also, very importantly, talking with your colleagues across disciplines, super important. Rana, anything you'd like to add to that?
I think in addition to what Brent and Guy have said, I would say ask early and assume nothing. You will be very surprised with what you hear. And as I said, being a pediatrician, I would start that conversation very early on in the teenage years, because you'll find a myriad of different responses which are very different to what you would have expected from the individual as a child.
Thank you all.
Can I add one thing, Yamini?
Oh, absolutely, Shannon.
Which is to say that structural barriers are not highly effective family planning. And so we need to ask these questions of all people, and family planning or preventing pregnancy can be a really important part of safer conception also. So this is why it's important to ask early and assume nothing. I love that from Rana, of really everyone.
Thank you, Shannon, for that addition. That's really how we function here at HIVE too. It's really about reproductive desires, or the lack thereof, belonging to people of all genders and sexual orientations. And so we've kind of embodied that work in the tools that we've created. So that's a great segue. I will just quickly mention that for the post Hangout blog, please visit the webpage for this Hangout, which is easily accessible through HIVEonline.org. Also, there is a whole section for resources pertaining to men living with HIV. It houses many of our printables, videos, blogs, etc. on topics like family building, disclosure, safer conception, preventing pregnancy, because as Shannon just said, that is a very important option. And Pete spoke to that earlier too. Treatment as prevention as a very, very important option for families, couples affected by HIV, PrEP, about fatherhood, and much, much more. Shannon and Guy briefly mentioned that they co-facilitate a reproductive health clinic for men, and they've started doing Facebook Live sessions as well, so you'll see more and hear more about that. Please contact us for more details, info@HIVEonline.org. Also, you can text the number, text this number, You can continue to text this number with questions you may have, and we'll be happy to triage you for the right person. With that, I'd like to begin to close out. What I want to say is that moving forward, we must see our clients, our patients, as whole people with a variety of preferences around their sexual and reproductive needs and wants. The question I have for the audience is, how will you champion sexual and reproductive health needs of men living with HIV in your work from here on out? Thank you for tuning in. Thank you, Brent Sugimoto out of Oakland, Guy Vandenberg, San Francisco, Rana Chakraborty, Atlanta, Shannon and Pete, also in San Francisco. And that's it for now. More to come. Thank you very much. This was Hangouts with HIVE.